Welcome back for another deep dive.
Glad to be back.
This time we're talking about something super practical, something you guys face every single day, whether you're nursing students or already out there working as pros. Figuring out how to use clinical evidence to make, the best possible decisions for your patients.
It's a jungle of information out there.
Oh, tell me about it.
So many studies, guidelines, expert opinions.
Yeah, and how do you sift through all of that and figure out what really matters? What's actually going to make a difference for the person sitting in front of you?
That's exactly what we're diving into today.
That's what this deep dive is all about, helping you develop a framework.
A framework for making sense of it all.
Whether it's like a brand new study on some cutting-edge treatment.
Or even just like a simple physical exam finding. How do you interpret that and what does it mean for your patient's care?
Let's just start at the very beginning.
Okay, love it. Back to basics.
You've got a patient right there in front of you. Maybe you're in a clinical rotation. Maybe you're seeing them in your own practice. Where do you even begin to, apply evidence? Where's the starting point?
Well, it always starts with the patient's story,
Okay.
their history, and their symptoms. I always tell my students, think of yourself as a detective.
Oh, I like that. Detective.
Yeah.
Way more fun than paperwork.
Right. So much more interesting. You're gathering those clues, those pieces of the puzzle that'll ultimately help you figure out what's going on.
So walk us through it. How do we start gathering those clues?
Okay, so let's imagine a scenario here.
Right.
You have a 43-year-old woman, and she comes into the clinic or the ER,
Okay.
complaining of intense pain in the upper right part of her abdomen.
Uh-huh.
And she tells you that this pain started after a meal, a fatty meal, to be specific. And along with the pain, she's also feeling nauseous, she's been vomiting, and she has absolutely no appetite. So what do you make of that? What are you thinking so far?
Okay. So just based on what you told me, I'm already thinking about the location of the pain, that upper right quadrant.
Right.
The fact that she has these specific symptoms, nausea, vomiting, no appetite, and even that little detail about the fatty meal, that seems important.
It is.
These are all clues, right? Like breadcrumbs leading us somewhere.
Exactly. You're on the right track. Each piece of information, no matter how small it might seem, helps you narrow down the possibilities.
So what are we thinking?
So in this case, it could be cholecystitis.
Okay, inflammation of the gallbladder, right.
You got it. But we also have to consider other things. It could be biliary colic or maybe even hepatitis. The point is, it's not just about confirming a diagnosis.
Right.
It's about ruling things out.
I see. So you're kind of creating a mental list of possibilities.
Yes. A differential diagnosis.
Right, right.
And then systematically using those clues, those clinical findings, to narrow it down.
That makes sense. So we've gathered our clues. We've got our list of suspects. What's the next step in our detective work? How do we move from these initial clues to actually using evidence to make decisions about what to do next for this patient?
That's where diagnostic tests come in.
Okay, yeah.
I think we can all relate to this, whether you're a student or you've been in practice for a while. The sheer number of tests out there, it can feel overwhelming.
Totally. And then trying to figure out what the results actually mean?
Right.
It can be a real struggle. I remember back in nursing school, feeling completely lost trying to decipher all those sensitivity and specificity numbers.
Oh, yeah. It's like a whole different language.
Exactly.
So let's break it down. Let's make it a little bit easier to understand.
Please.
Let's start with sensitivity. Sensitivity tells you how good a test is at correctly identifying the people who do have the disease.
Gotcha. So a highly sensitive test is going to catch most of the cases.
Exactly. Then you have specificity.
Okay. And that's like the flip side.
It is. Specificity tells you how good a test is at correctly identifying the people who don't have the disease.
So a specific test is really good at ruling things out.
You got it. You're getting it.
Okay, so far so good. But then there are these things called positive and negative predictive values.
Right. And those can be a little trickier.
They definitely trip me up in school.
Yeah, I think they trip a lot of people up. Basically, they tell you the probability of actually having the disease based on a positive or negative test result.
Okay, so it's not just whether the test is positive or negative, it's also about how likely it is that the result is actually accurate.
Exactly. It takes into account the prevalence of the disease in the population.
Okay, so, if a disease is really rare...
Even a positive test might not be that reliable.
Right, because the chances of having the disease are just lower to begin with.
That's it. And then, to make things even more interesting, we have these things called likelihood ratios.
Oh, yeah. Likelihood ratios, those always sounded a bit intimidating to me. I knew they were important, but I wasn't always sure exactly how to use them.
They're actually incredibly useful once you get the hang of them. Think of it this way. They tell you how much a positive or negative test result actually changes the probability of the patient having the disease.
Okay, so it's not just about whether the test is positive or negative.
It's about how much that result shifts our thinking, how much more confident or less confident it makes us in the diagnosis.
So let's go back to our patient with the abdominal pain. If we did a Murphy's sign test, and it was positive.
Meaning they have pain when you release your hand from their abdomen.
Right, suggesting gallbladder inflammation. A likelihood ratio would tell us how much that positive Murphy's sign increases the likelihood that they actually have cholecystitis.
Precisely. A high likelihood ratio would make us much more confident in that diagnosis.
This is making me realize that interpreting test results is a lot more nuanced than I initially thought.
It definitely is.
It's not just black and white, positive or negative.
Nope, it's about shades of gray. And remember, that prevalence thing we talked about, that plays a role here too. The same test can actually have different levels of accuracy depending on how common the disease is in the community.
Wow, that's fascinating. So a test that might be really reliable in one population
Might not be as reliable in another.
it really makes you think differently about interpreting test results. You can't just look at the numbers in isolation. You have to consider the whole picture.
Context is everything, and this is especially important when we're talking about screening tests.
Oh, absolutely. Something both nursing students and experienced faculty are dealing with all the time, like mammograms, colonoscopies, pap smears. These are tests that are done on people who don't necessarily have any symptoms. And sometimes the results can be a little bit, well, confusing.
And anxiety-provoking.
Yes, especially for the patients. Like, imagine getting an abnormal mammogram. How do you even begin to make sense of the numbers and then explain them clearly to someone who's probably feeling pretty freaked out?
It's a tough conversation to have, but there are some really powerful tools that can help.
Like what?
Well, one of them is called the Fagan nomogram. It's basically a visual tool that helps you revise the probability of a disease, in this case, breast cancer, based on the mammogram result and the patient's baseline risk.
So it takes into account more than just that one test result.
Exactly. It factors in their age, family history, and other risk factors, and it helps you communicate that risk in a way that's more understandable.
That's really cool. Are there any other tools that can help us navigate these tricky situations?
Another approach is to use something called natural frequencies. Basically, you're breaking down statistics into terms that are easier to grasp. So instead of saying something like, there's a 10% chance of having breast cancer, you could say, out of 100 women with a similar mammogram result, about 10 will actually have breast cancer.
Oh, wow. That makes so much more sense. It's way more concrete and easier to visualize.
Exactly. It's about finding ways to make the information clear, understandable, and relevant to the individual patient.
So they can truly be involved in making informed decisions. This is already making me rethink how I approach these conversations. It's not just about giving information. It's about making sure the patient really understands what that information means for them. But before we move on to communication, there's something else that's been on my mind. We rely on physical exam findings, like that Murphy's sign we talked about, to help guide our diagnoses.
Yeah.
But sometimes those findings can be a bit subjective, right? Like what I consider a positive Murphy's sign, another clinician might not. So how do we know if our assessments are actually reliable?
You're absolutely right. It's a great point. And I'll admit, it's something that I've wondered about myself over the years.
Yeah, I mean, you see variations in how different clinicians assess the same patient, and it makes you wonder how much we can truly trust our own observations.
Right. It's like, are we all on the same page here?
Exactly. So how do we address that?
Well, there's a way to actually measure that agreement, and it's called the kappa score. It tells you how much of the agreement between, say, two clinicians assessing for Murphy's sign is beyond what you'd expect just by chance.
Okay, I think I'm following. So if two clinicians agree on a positive Murphy's sign 80% of the time, the kappa score would help us understand if that agreement is actually meaningful or if it's just a fluke.
Exactly. It helps us determine the level of reliability in our assessments.
And that same concept of reliability applies to other areas too, right? Like lab tests.
Absolutely. Think about the concept of precision. If a test has low precision, meaning the results can vary a lot even for the same patient, it can lead to some pretty questionable decisions about their care.
Oh, wow. That's a bit unsettling. So not all tests are graded equal?
Nope, they definitely aren't. And that's why it's so important to understand the limitations of the tools we're using.
Okay, so we talked about understanding the patient's story, deciphering diagnostic tests, navigating the world of screening tests, and even thinking about the reliability of our assessments. But there's still this massive amount of research out there, articles, studies, guidelines. It's like a fire hose of information.
It can definitely feel overwhelming.
It totally is. So how do we even begin to keep up with it all? And more importantly, how do we know what's actually worth paying attention to?
Well, it doesn't have to be as daunting as it seems. There's a really straightforward 3-step process for critically appraising clinical evidence.
Okay, tell me more about that.
It starts with asking yourself a very simple question. Are these results believable?
So it's not just about taking the results at face value.
No, it's about digging deeper. It's about looking at the study itself and asking some critical questions.
Like what? What are some of the things we should be looking for?
Well, one of the biggest things is bias. Different types of bias can creep into research studies and skew the results. And we need to be aware of that.
Okay, bias. So what are some examples of bias?
There's selection bias, where the groups being compared aren't really comparable. There's performance bias, where the way the intervention is delivered differs between the groups. And there's detection bias, where the way outcomes are measured is different. And these are just a few examples.
Wow, I never realized there were so many different types of bias that could affect the results of a study.
Yeah, there are a lot of potential pitfalls, and it's easy to overlook them if you're not really paying attention.
So once we've figured out whether the study is even valid, what's next?
You move on to the results themselves. What did the study actually find, and how big was the effect? Is it clinically significant?
So it's not just about statistical significance.
Right. It's about whether the findings actually matter in the real world, whether they're going to make a difference in how we care for our patients.
That makes sense. So we've looked at the validity of the study, we've scrutinized the results. What's the final piece of the puzzle?
Generalizability. Can you apply these findings to your patients? Do they match the demographics of your patient population? Is the intervention feasible in your setting?
Oh, right. Just because a study shows that something works in one context doesn't necessarily mean it's going to work in another.
Exactly. And you have to consider the potential benefits and harms for your specific patient.
This is a great framework. It's like a roadmap for navigating the research jungle.
I'm glad you find it helpful. It's about giving you the tools to think critically about the evidence and make informed decisions.
Not just blindly following guidelines or the latest trends.
Exactly. You have to be able to evaluate the evidence for yourself.
Which brings us to what might be the most important part of all this, communicating all of this knowledge to our patients.
Absolutely. It's one thing for us to understand the evidence, but if we can't communicate it clearly and effectively to our patients, it's all for nothing.
Right, because ultimately we want our patients to be involved in their own healthcare decisions. We want them to be partners in their care.
Exactly. So let's explore the art of communicating clinical evidence in a way that empowers patients, builds trust, and leads to shared decision-making. It's definitely easier said than done, though, right?
Oh, yeah, for sure. I mean, we're dealing with complex medical information. It's often full of jargon and technical terms.
And our patients might be feeling all sorts of things, anxious, overwhelmed, maybe even distrustful of the healthcare system. So how do we bridge that gap? How do we make sure we're really connecting with them on a human level?
That's the million-dollar question, isn't it?
It is, and I think it all comes down to clear, unbiased communication. Think about it like how you discuss the results of a screening test, like that mammogram we were talking about earlier, instead of just saying, the test was positive.
Which is pretty scary to hear.
Right. It doesn't really tell the patient anything useful.
No, it doesn't.
So instead, you could say something like, the mammogram showed an area that we need to look at more closely, but we need to do some further tests to be sure. You're explaining what that positive result actually means.
Yeah, that makes a lot more sense. You're not sugarcoating it, but you're also not, alarming them unnecessarily. And you're giving them a clear next step.
Exactly. And I think it's also really important to talk about the limitations of tests.
Okay, that's a good point.
No test is perfect.
Definitely not.
And it's important for patients to understand that.
So they have realistic expectations.
Right. And they don't free out if, a test isn't 100% conclusive. I remember one of my instructors in nursing school used to say, it's not what you tell them, it's what they hear.
Oh, that's so true.
And I think that's stuck with me all these years. We need to make sure our patients really understand what we're saying, not just hear the words, but actually process them and integrate them into their own understanding of their health.
And that might mean what? Like using visual aids, drawing pictures.
Sometimes, yeah. Or analogies, comparing it to something they're already familiar with. Or even just repeating the key points a few different ways, just to make sure it's really sinking in.
And I think it's also important to check for understanding along the way. Like asking things like, what are your thoughts so far? Or does that make sense to you?
Absolutely. You want to make sure you're having a conversation with the patient, not just lecturing at them. It's a two-way street.
Definitely. And I think it's also important to remember that, emotions play a huge role in healthcare decisions.
Oh, for sure.
People might be scared, confused, even in denial.
All the time.
Yeah. And I think acknowledging and validating those emotions can go a long way in building trust.
Huge. It makes it so much easier to have those tough conversations. It's kind of like that saying, people don't care how much you know until they know how much you care.
Oh, I love that. Empathy is so crucial.
It really is. And sometimes I think it's not even about giving information.
Huh.
It's
Okay.
more about helping patients connect with their own values and priorities.
So, what matters most to them in this situation?
Exactly. What are their goals? What are their biggest fears?
And then figuring out how the evidence can help them achieve those goals.
Right. It helps shift the focus from a purely medical decision to something that's much more personal and meaningful.
I love that. It gives them agency. This is making me realize that there's a real art to communicating evidence.
It is an art.
It's about finding that balance between, like, giving them the information they need.
Without overwhelming them.
Right, and without being judgmental. And respecting their autonomy.
Absolutely. And luckily, there are some really helpful frameworks and resources that can guide us. Have you heard of the 5 A's approach?
The 5 A's. I feel like I should, but could you remind me?
Sure. It stands for ask, advise, assess, assist, and arrange.
Okay, and that's like a structured way to approach patient communication.
Exactly. It's like a step-by-step guide. You start by asking about their understanding and their concerns. Then you advise them based on the evidence. And then you assess their willingness to make changes. And then you assist them in actually making those changes. And finally, you arrange follow-up care.
That's a great framework. I'm definitely going to be using that. What about, you mentioned something called frames earlier, I think.
Oh, yeah. FRAMES. It stands for feedback about personal risk, responsibility of the patient, advice to change, menu of options, empathetic style, self-efficacy. It's kind of a mouthful.
It is, but it sounds important. What's it all about?
It's all about emphasizing personalized risk communication and empowering patients to take ownership of their health decisions. It's about giving them a menu of options and supporting them in choosing the path that's right for them.
I like that. And then there are things like decision aids, right?
Oh yeah, decision aids are amazing. They're basically tools that give patients clear, unbiased information about different treatment options and like the potential benefits and harms of each option. And they can be really helpful for patients who are struggling to make a decision.
Oh, that's great. So are those like pamphlets or like interactive websites?
They come in all sorts of forms, but the key is that they present the information in a way that's easy to understand and digest. And then they help patients clarify their values and preferences. There's actually a lot of research showing that decision aids can improve patient knowledge, reduce decisional conflict, and even lead to more active participation in the decision-making process.
Wow. That's really impressive. This whole conversation is making me realize that communicating clinical evidence isn't just like a box to tick on a checklist. It's actually a really crucial part of patient-centered care.
I couldn't agree more.
It's about building trust, empowering patients, and working together to achieve the best possible outcomes.
It's about partnership, and I think that's what makes nursing so special.
It really is. All right, so before we wrap up this deep dive, let's take a minute to recap some of the key points for our listeners, whether you're, a future nurse just starting out on your journey or you've been in the trenches for years.
Love it. Let's hit those highlights.
Okay, so we started with that crucial first step, understanding the patient's story.
Gathering those clues.
Being a detective, remembering that every little detail could be important.
Exactly.
And then we moved on to exploring the world of diagnostic tests.
Oh, yeah, all those numbers.
All those numbers. We untangled some of those, like, sometimes confusing concepts, sensitivity, specificity, and we talked about those ever-so-helpful likelihood ratios.
Which tell you how much a test result actually changes the probability of a diagnosis.
Right, and we can't forget about the importance of prevalence, that often overlooked factor that can really change how we interpret a test's predictive power.
Context is everything.
It really is. We also tackled screening tests, especially those tricky situations, like when you get an abnormal mammogram result. And we talked about how clear communication is so essential in those moments when patients are probably feeling a lot of anxiety.
Yeah, those conversations can be tough.
For sure. And that's where tools like the phagonomogram and the concept of natural frequencies can be really helpful.
They help us make sense of the numbers and explain them to patients in a way that they can actually understand.
Right. We also talked about the human element of all of this, how to make sure that our own assessments as nurses are actually reliable.
Yeah, because we all have our own biases and blind spots.
Exactly. So we talked about using the kappa score to measure agreement.
And understanding the importance of precision in lab tests.
To make sure we're making good decisions. And then there's that mountain of research that we all face. The articles, the studies, the guidelines. It can be so overwhelming.
The fire hose of information.
It totally is. So we learned a 3-step process for critically appraising clinical evidence, starting with checking the validity of the study itself.
Making sure it's well-designed and trustworthy.
Right. And watching out for those sneaky biases that can creep in and distort the results.
There are so many of them.
I know. And then we have to look closely at the results themselves, figure out how big the effect really is and what it actually means in practical terms.
Statistical significance versus clinical significance.
Right. And then finally, we have to think about generalizability. Can you apply these findings to your own patients in your own practice setting?
It's not a one-size-fits-all situation.
Definitely not. So it's like we have a mental checklist now for evaluating research and making sure we're making decisions based on solid evidence.
And not just following the latest fads or trends.
Exactly. But all of this knowledge is only useful if we can communicate it effectively to our patients.
Right. It all comes back to that.
Which is why we spent so much time today diving into the art of patient communication. We talked about using clear, unbiased language, tailoring our approach to each individual patient, and creating a space for, like, real dialogue and shared decision-making.
Because ultimately, it's the patient's decision.
Yes, we're there to guide and support them. We talked about some helpful frameworks like the 5 A's and frames.
And those fantastic decision aids that can empower patients to make choices that really align with their values.
It's about moving away from that, like, old-fashioned paternalistic model of healthcare and really creating a true partnership with our patients.
I couldn't have said it better myself.
So as we wrap up, I want to encourage all of our listeners to, like, keep learning, keep questioning, and keep striving to be the best nurses you can be.
The learning never stops.
It definitely doesn't. All right, that's it for this deep dive. We'll catch you next time.
See you then, 26CO.